Channel. Now we are going to start a dermatology complete revision of first aid. So in dermatology we'll start with the skin. So we know that skin is the largest organ of the body, and actually skin is made up of three layers. The first one is called epidermis, and the next one is called dermis, and the next one is subcutaneous fat, which is not shown here. Actually it is below this dermis. Okay, below the dermis you have subcutaneous fat, which is also called as hypodermis or subcutis. Okay, so how to remember this layers of epidermis? Especially epidermis is divided into many layers, like you can remember it. Come, let's get sunburned. CLGSB. Come, let's get sunburned. Okay, that is epidermis. Below that you'll have dermis. Okay, actually epidermis is made up of squamous epithelial cells, and the first layer in the epidermis is stratum corneum, which is containing anucleated cells. See, no nucleus, and keratin filaments are present. Next, coming to stratum lucidum, we can see a clear dead skin cell layer. Next, coming to stratum granulosum, which is mainly containing keratohyalin granules. Next, stratum spinosum, which is having desmosomes. Next, stratum basale, which is leading to formation of stem cells. Next comes the dermis. Dermis is having mainly connective tissue and blood vessels. Next, the subcutaneous fat. Okay. Now let us see the epithelial cell junctions. Actually, epithelial cell junctions are divided into 1, 2, 3, 4, 5 types. Okay, so first one is a tight junction. So tight junction is mainly also called zona occludens, because here the proteins which are involved are occludin or claudin. So according to the name of this protein, we can remember the name zona occludens or tight junction. So it prevents the paracellular movement of solutes, right? And it is mainly composed of claudin occludin. Okay, this is the picture. Next, coming to uh, adherens junction. It is a belt desmosome, or also called zonular adherens. It forms a belt like structure. You can see the belt like structure connecting actin cytoskeletons of adjacent cells with cadherin. So actually here there is a belt like formation between two adjacent cells with cadherin, which is a calcium dependent adhesion protein. So loss of cadherin is seen in metastasis, especially you see that in breast cancer. So because two cells are not getting adhere with each other, they are getting metastasis to other places. That is a problem in breast cancer. Okay, cadherin or cadherin is nothing but calcium dependent adhesion molecules. You can see belt like structures. Next, coming to desmosome. Desmosome is a spot desmosome or macula adherens. They are like structurally supporting by means of intermediate filament interactions. You can see here in this diagram, these are the intermediate filaments. So because of that interactions, the two cells are getting bound with each other. There are some autoantibodies to this desmoglein 1 or 3, which is seen in a pemphigus vulgaris. This is a skin disease. In this disease, pemphigus vulgaris, there is autoantibodies against desmoglein 1 or 3, and that is leading to disruption of this desmosome. Next, coming to gap junctions. It is a channel protein called connexins. Connexins are connecting these gap junctions. They permit electrical and chemical communication. So that is the name, gap junctions. They are permitting the connection. Next, coming to hemidesmosome. They are connecting the keratin in basal cells to underlying basement membrane. Actually, I drawn this diagram here. Actually, this is a basal membrane. For example, basement membrane. The cells are connected to the basement membrane because of this hemidesmosomes, and they are also having a integrin proteins. You can see here integrin, fibronectin or laminin. Actually, basement membrane is divided into two types. One is basal lamina, one is reticular lamina. This above one, this you can see, this is a basal lamina. This below one is a network formed reticular lamina. So basal lamina contains laminin and type 4 collagen. Reticular lamina contains reticular connective tissue, which anchors the basal lamina to the connective tissue. Okay, so actually basement membrane anchors epithelial cells to the connective tissue. So hemidesmosome is using that function. It is connecting the epithelial cells to the basement membrane by means of integrin, fibronectin and laminin. Actually fibronectin and laminin are part of basal lamina of basement membrane. Okay, so because basal membrane of basement membrane is integrating with the epithelial cell, okay, with integrin, fibronectin, laminin, ECM, collagen. Hemidesmosome is useful for that. Okay, some autoantibodies are against the underlying basement membrane. You can see cells to underlying basement membrane. Next, autoantibodies against this are called bullous pemphigoid. That is, hemidesmosomes are down below. You can remember like that. In bullous pemphigoid, there are autoantibodies against hemidesmosomes, whereas there are autoantibodies against desmoglein and 1 and 3 is in pemphigus vulgaris. Okay. So integrity of basement basolateral membrane by binding to collagen, laminin, fibronectin in basement membrane. Integrins membrane proteins that maintain this integrity. Next, coming to keratin monomers, actually they assemble and they form the intermediate filaments. Next, coming to the glands, you know that we have endocrine glands and exocrine gland. Endocrine gland produce hormones, exocrine don't produce any hormones, but they secrete by means of a duct. Okay, so endocrine glands are divided into three types: merocrine, secretion, apocrine, holocrine. In merocrine secretion, there are secretory vesicles. In apocrine secretion, there will be pinched portion of cell, and in holocrine secretion, the whole cell will disintegrate and it will release. So merocrine examples are salivary and sweat glands. You see this type. Apocrine is seen in mammary glands, pinched portion. Okay, holocrine is seen in sebaceous gland, which is present in the skin. Now let us discuss about the dermatological macroscopic terms. So for this we need to see along with the diagram, we'll understand. The first one I'm going to discuss is macule. So you can see here, this is a macule. Actually it is a flat lesion with well circumscribed change in skin color. You can see this black color. It is less than 1 centimeter. Freckles are seen actually on the face. That is also example of macule. Okay, so you can see macule examples: freckle, labial macule. I showed labial macule. Freckle is actually on nose, between nose and eyes. You'll get this. Actually this is because of increased melanin production, and it will also darken on the sun exposure. Okay, and next coming to patch. Patch, as you can see, the macule, it is also a macule. So macule, patch is also a macule, but it is greater than 1 centimeter. It is large birthmark. It is also called congenital nevus. Next coming to papule. So papule is actually elevated solid skin lesion which is less than 1 centimeter. You can see clearly papule. It is a mole, example mole, or acne. Acne can also be a papule. So mole, acnes are papules, patches you can clearly find, macule you can clearly find now. Okay, differentiate now: macule, patch, papule. Next coming to plaque. Plaque is a papule but it is greater than 1 centimeter. Example is psoriasis. Next coming to vesicle. Vesicle is small fluid filled blisters. You can see clearly some fluid is present, blisters. Okay, and they are less than 1 centimeter. Example in chicken pox, shigella, zoster, all this. Next coming to bulla. You can see a bulla here, a large fluid filled like substance. Actually it is large fluid blister greater than 1 centimeter. It is bullous pemphigoid. Okay, this is a bullous pemphigoid. Next coming to pustule. Pustule is actually a vesicle containing pus with some white centers. It is pustular psoriasis. Next coming to a wheal. WHEAL. Okay, wheal is actually itchy and it is a transient smooth papule or plaque which is surrounded by erythema, some redness you can see here. It is hives, actually urticaria caused by dermal edema. Next coming to scale. Scale is flaking of stratum corneum. You can see the stratum corneum is the first epidermal layer. It is like flaky structure, and this is due to eczema and psoriasis, also seen in squamous cell carcinoma. Next coming to a crust. You can see the crust in the baby. A crust is a dry exudate. It is an impetigo. And one more thing, there's a maculopapular rush. That is, some of the macules are flat and some are raised black papules. So it is called maculopapular. It is mainly seen in the drug, because of some drugs it may cause, or because of scarlet fever, because of syphilis, because of rubella it may cause. And there is also a morbilliform which looks like measles. Next coming to, before going to that, we need to see that this dermatological this all macule, papule, all this are divided into two types. One is primary lesion, that is because of some disease. Macules is because of disease. Papules is because of disease. Vesicles, bullas, okay, all these are because of some disease. Whereas secondary lesions are because of trauma and external factors like scale, crust, erosion, fissure, ulcer. These are secondary. Now coming to dermatological microscopic terms, that is a Dyskeratosis. It is abnormal premature keratinization. So prematurely only there is keratinization. It is seen in squamous cell carcinoma. Next, hyperkeratosis. That is increased thickness of stratum corneum. You know, stratum corneum is the first layer of epidermis. Because of increase in keratin, this problem is going on. It is seen in psoriasis and callusis. Parakeratosis is retention of nuclei in stratum corneum. Actually, stratum corneum is enucleated, but if there is nuclei, that is called parakeratosis. It is also seen in psoriasis, actinic keratosis, and malignancies. Next, coming to hypergranulosis, that is increase in thickness of stratum granulosum. This is seen in lichen planus. I'll discuss about this. This is also in future videos. Spongiosis. Spongiosis is epidermal accumulation of edematous fluid in intercellular spaces. In between intercellular spaces, there's edematous fluid, and it is due to eczematous dermatitis is seen in that. Next, acantholysis. This separation of epidermal cell, that is loss of connection between keratinocyte and loss of desmosome. So because of that, there is acantholysis. There is pemphigus vulgaris is example of this. You remember pemphigus vulgaris, there are autoantibodies against desmoglin 1 and 3. So there will be loss of desmosome. Next, coming to acanthosis. It is epidermal hyperplasia. Especially in the spinosum layer. So there are elongated rete ridges which are present, and examples is acanthosis nigricans, that is hyperkeratosis, psoriasis. So actually there are three types of things you can see. Fissure in a skin. Fissure in a skin is a narrow tear with all walls, epidermis and dermis. It involves all layers. Erosion is where it only involves the epidermis. Ulcer involves the epidermis and dermis. Now coming to pigmented skin disorders, that is albinism, melasma, vitiligo, Waardenburg syndrome. So first one is albinism. Actually, it's a normal melanocyte number. Here the melanocyte in this female, if you see, she has become so much white and somewhat pinkish color. This is because of albinism. It is an autosomal recessive disorder. You can also see the white hair, pinky skin, and eyes will be blue. Okay, actually this is a condition where there is decreased melanin. So if melanin will be more, then it will lead to black color, right? If melanin is very low, that will lead to this white pinkish color of skin, and hair also will change its color. But the melanocyte number still is normal here. It is mainly due to decrease in tyrosinase activity or defective tyrosine transport, because melanocyte is actually produced from amino acid tyrosine. So first, if we understand something about melanin, then we can understand this disease. Melanin is usually coming from amino acid tyrosine. It gives color to skin and hair. It protects us from UV radiation, okay? And it is synthesized mainly in melanocytes, and these melanocytes are derived from neural crest cells. Melanocyte is specialized secretory cell. It is found in basal layer of epidermis. Okay, if you remember, that is stratum basal layer. In that epidermis, there you will find melanin. Synthesis melanin in melanosomes. Again, it is transferred to keratinocyte. Okay, so this is very important about melanin. So now you can understand, if there is no melanin, the skin and hair will become white because there is no melanin. And there is also problem here because of decreased tyrosine activity. So of course it will lead to this color. There is increased risk of skin cancer, sunburns, and also no UV protection for these people because there is no melanin. It is also called oculocutaneous albinism. Next, coming to melasma. Melasma is also called coalasma. Okay, cloasma. Actually, it is because of acquired hyperpigmentation associated with pregnancy and OCP use. You can see in this patient here, symmetrical, there is some black pigmentation. That is because of some pregnancy or OCP use. It is more common in patients already who are having darker skin. It is symmetrical and sun exposed on face. Actually, if there is more sun exposure, this will increase this melasma. It is symmetrical. Treatment is hydroquinone. Next, coming to vitiligo. Vitiligo is actually irregular patches. You can see irregular patches, complete depigmentation. Actually, this person is somewhat black in color, but you can see this white patches. This is nothing but vitiligo. It is caused by destruction of melanocyte, believed to be autoimmune. Autoimmune destruction of melanocyte, associated with some other autoimmune diseases also. Next, another one is Waardenburg syndrome. It is patchy depigmentation of skin, hair, and also iris that can be associated with deafness. So it is somewhat same like vitiligo, patchy depigmentation, but it is also causing deafness. It is caused by defects in differentiation of neural crest cell into melanocyte, because neural crest cell only giving rise to melanocyte. So some problems in neural crest cell that is leading to some problem in melanocyte, that is a Waardenburg syndrome. Next, coming to seborrheic dermatitis, you can see here some redness side of nose. Actually this is erythematous well demarcated plaque, greasy yellow scales in areas which are rich in sebaceous gland, such as you can see this in scalp, face, periocular region, common in infants and also in adults. It is associated with Parkinson's disease. Sebaceous glands are not inflamed but play a major role in disease development. It is associated with Malassezia species, that is a fungal infection. Treatment is antifungals and glucocorticoids. So this is a fungal infection causing this red color, especially in areas like scalp, face, where there is rich in sebaceous gland. Okay. Now let us discuss some of the skin problems. The first one is acne. So acne are actually having some different multi reasons. Main reason is increase in sebum. Whenever there's increased sebum, whenever increased androgen production or abnormal keratinocyte desquamation, that is leading to this acne. That is leading to especially blockage. Actually main cause is blockage of sebaceous gland. So when sebaceous gland is blocked, sebum will be increased, and that will lead to attract more bacteria, especially QT bacteria is attract, and that will lead to colonization of pilosebaceous unit. Pilosebaceous means actually hair follicle is also involved along with this, and that is called comedons. Comedons are blocking the sebaceous gland, leading to inflammation. So papules and pustules, these are the papules and pustules, these are formed. Nodules or cysts may also form. So you can see here the major bacteria is Propion bacteria, which is anaerobic bacteria, and the treatment is retinoids, benzoyl peroxide, and also antibiotics. Retinoids are teratogenic if given to patients who are pregnant, and this is effective hormone responsive gland. So wherever the face, neck, chest, upper back, here it is involved. There are open comedia called blackheads and closed comedia called whitehead. Blackhead is nothing but where the sebaceous gland is blocked, so that debris will appear upon it. If it is covered by somewhat skin or some white color, then it is called whitehead. Inflammation or lesion may cause papules, pustules. In adolescents, acnes are more common, especially in males. In females, or you can see acnes because of increased androgen, PCOS, it will form acne. In blocked ducts, increased sebum plus keratin and increased bacteria. Okay. Next, coming to atopic dermatitis. This is a type 1 hypersensitivity. It is a prurite eruption commonly on skin flexures associated with atopic disease like asthma, allergy, food allergy. Here IgE is increased. Mutations are seen especially in filaggrin gene, and this predisposed via skin barrier dysfunction. Often appears on face in infancy. You can see here in infants it is seen mainly. So, and then in antecubital fossa in children and adults. So it is because of mutation in filaggrin gene. Actually it is skin barrier, okay, via skin barrier dysfunction because of allergies, increase IgE, type 1 hypersensitivity. Next, coming to allergic contact dermatitis. It is type 4 hypersensitivity secondary to contact allergens like nickel, poison, neomycin. Okay. Next, coming to actually this is D and E. Even this both are coming under this allergic contact dermatitis. Some allergens are contacted, so it is causing this. Next, coming to F and G. This is melanocytic nevus. So melanocytic nevus is a common mole. It is benign, but melanoma can arise sometime. There is dysplasia because of dysplasia seen in congenital or atypical moles. Intradermal nevi are papular. If you see, this is intradermal nevi, which is papular, okay, and junctional nevi are flat macules. Junctional nevi are flat macules. These are junctional nevi. These are acquired childhood, especially in adolescents. Peak is in 30 years. It will regress with age. Actually, acquired nevi divided in three types. Junctional nevi, they grow along dermal epidermal junction, found in children. Compound nevi grow into dermis. Intradermal are seen in dermis, common in adults. Okay, next, coming to this one, that is psoriasis. Okay, psoriasis is autoimmune HLA-C association, papules and plaques with silvery scaling. You can see especially on knees and elbows it is present, and this is acanthosis with parakeratotic scaling, that is nuclear present in stratum corneum. There are Munro microabscess, that is neutrophil in stratum corneum, increased stratum spitosum, decreased stratum granulosum. There is also asput sign, that is pinpoint bleeding spots from exposure. You can see this is a bleeding spot from exposure of dermal papilla when scales are scraped off. So if you remove the scales, you can see these bleeding points. It is associated with nail pitting, psoriatic arthritis, ankylosis. Okay, all this. Sorry, not ankylosis, onkylosis. That is a fingertip. Finger is this nail is coming out of it, nail bed. Okay, next coming to rosacea. Actually, it is seen in northern European people. Actually, it is inflammatory facial disorder by papules, pustules, no comedians, associated with facial flushing, response external similar like alcohol, heat. Complications include ocular involvement, rhinophyma, bulbous deformation of nose. You can see cheeks, especially nose cheek. There is redness, especially Europeans. Okay, rosacea. Next, coming to seborrheic keratitis. Seborrheic keratitis is a flat, greasy, pigmented squamous epithelium proliferation, immature keratinocytes, very important, with keratin filled cyst, horn cyst. Okay, and they look stuck on. Lesions occur on head, trunk, extremities. Common benign neoplasm in older persons. Next, coming to lesser trait sign. It is rapid onset, multiple seborrhokeratosis, indicates possible malignancy, especially GI adenocarcinoma due to cytokines. Actually, it is from velvety surface. Okay. Next, coming to verrucea. Verrucea, you can see is warts caused by low risk HPV. Okay, low risk HPV strains, soft tan colored, cauliflower like papules, epidermal hyperplasia, keratosis, choleliocytosis, condyloma acuminata on anus and genital regions it is seen. So actually, among Verrucea vulgaris is most common, plana is flat wart, and it is vulgaric is most common in hands, and that will lead to epidermal hyperplasia. Next, finally, urticaria. It is hives, pruritic wheals that form mast cells, degranulation, characterized by superficial dermal edema, lymphatic channel dilation. Coilocytosis is present, that is cytoplasmic halo around nucleus. Okay, so these are the conditions which are very important. Vascular tumors of skin. So vascular tumors of skin, according to the name we can find out the disease. So first one is angiosarcoma. Angio means blood vessel, sarcoma means mesenchymal origin tumor. So it is mainly seen in older white male between 65 to 70 years. Male is to female ratio is 2:1. Actually, it's a rare blood vessel malignancy, mainly occurring in head, neck and also breast areas. It is mainly due to sun exposed areas and associated with radiotherapy, chronic post mastectomy and also lymphedema. After lymphedema, there's a disease called Stewart-Travis syndrome. This occurs mainly after lymphedema, developing after chronic lymphedema. This is a cutaneous angiosarcoma, and hepatic angiosarcoma is associated with vinyl chloride arsenic exposure. And next, very aggressive and difficult to resect due to delay in diagnosis. So this is about angiosarcoma. Next, coming to bacillary angiomatosis. Actually, it's a benign capillary skin papule. You can see here, this is a skin papule of bacillary angiomatosis. It is found in patients with AIDS, and it is caused by Bartonella infection, frequently mistaken for capsuloid because both of them look same, but in bacillary angiomatosis there is neutrophilic infiltration, in capsuloid there is lymphatic infiltration. Next, coming to cherry hemangioma. You can see it's somewhat like a cherry, so the name, it is commonly appearing in middle-aged adults, but it cannot regress. Frequency will increase with age. It is a benign capillary hemangioma. Next, coming to glomus tumor. It is a bluish, benign, painful, especially seen under fingernails, arises from modified smooth muscle cells of thermoregulatory glomus body. Actually, glomus body is thermoregulatory, so if it gets modified and arises from this cells, then it causes this tumor. It is mainly painful when exposed to cold. Next, coming to capsuloid sarcoma. this is not capside. Capside sarcoma is endothelial malignancy, most commonly affecting skin, mouth, GI, respiratory tract. Classically seen in Eastern European males and patients with AIDS and organ transplant patient associated with HHV8 and HIV. And here the differentiation is lymphatic infiltrate. In bacillary angiomatosis, there is neutrophilic infiltrate. Next, coming to pyogenic granuloma. This is a polypoid lobulatory capillary hemangioma. This can ulcerate and also bleed, associated with trauma and also pregnancy. Next, coming to strawberry infantile hemangioma. In the name itself, you can see it is seen in infants. Benign capillary hemangioma appears in first few weeks of life, grows rapidly, and it can regress spontaneously by 5 to 8 years. Here there is excess proliferation of blood vessels. So first we need to understand what is blood blister. It is a traumatic bleeding, especially seen in dermis, because we know that in dermis only there are blood vessels, not in epidermis. So mainly bleeding from dermis. Cystic hygroma. Cystic hygroma is congenital malformation seen in newborns. It is a large cyst with some lymph and it's benign. It develops on neck and it is caused by obstruction of lymph drainage. So when lymph is blocked, the cyst form. It is found on prenatal ultrasound and it will also lead to increased risk of fetal aneuploidy malformation. There's increased risk of miscarriage or fetal death found together with nuchal transclerancy. Actually, nuchal transclerancy we see it in 13 weeks in the fetus. So along with nuchal transclerancy, you can also see this cystic hygroma. Next, coming to nevus simplex. Nevus simplex is a stroke bite or scorpion batch. It is capillary malformation common on eyelids and back of neck. It is actually a birthmark. It is a pink red macule. It fades in the first few years of life. Next, nevus flammus. According to the name, you can see flammus means red. It is also called port wine stain. Malformation of dermal capillaries and venules lead to this, associated to Sturge-Weber syndrome. Next, coming to skin infections. So there are bacterial infections and viral infections. So bacterial infections, the first one is impetigo. So in the diagram you can see this is a impetigo, how it looks. So impetigo is a skin infection mainly involving superficial epidermis. So if superficial epidermis is involved, especially by Staph aureus and Streptococcus pyogenes. So it is highly contagious and you can see somewhat honey colored crusting. This crusting, you can see honey colored crusting. Here the neutrophils are connecting beneath stratum corneum. You know, stratum cornea is the first layer of epidermis. So beneath that there are neutrophils. And this is a most common type. Remember, most common type is non-bullous type. Bullous means a cyst-like formation is not formed. That is most common. That is honey colored crusting is seen in non-bullous type, because that bullous has ruptured and it is forming this crusting like type. That is non-bullous, which is most common. There is another type called bullous type. That is some bullous are formed, like some pus fill like that, bullae are formed, and it is usually caused by Staph aureus. It is common in children and it is seen only in the trunk. Bullous impetigo is formed due to exfoliates which are accumulated by Staph aureus. They destroy desmoglein and affect stratum granulosum. Very important. In this you can see non-bullous form is contagious and it is mainly affecting the stratum corneum, whereas bullous impetigo is affecting mainly stratum granulosum. Now coming to another one, that is erysipelas. Erysipelas is actually infection involving especially upper dermis and superficial lymphatics. It is infected by pyogenes present with well-defined raised demarcation between infected and normal skin. Very clearly you can see normal skin infected. Most common seen in leg and face. Next, coming to cellulitis. So cellulitis is most common in elderly people. It is acute, painful, spreading infection of deeper dermis and subcutaneous. So erysipelas is only upper dermis. Cellulitis going to deeper dermis and sometimes even to subcutaneous tissue. It is usually from pyogenes and aureus. So it often starts with break in skin like trauma or another infection. It is spreading. You can see how it's spreading. Next, coming to another one, that is abscess. You can see some pus and infection. So this is a neutrophil and bacteria present. This is a collection of pus from walled off infection. It goes into deeper layers of skin. Main organism is Staph aureus. Next, coming to necrotizing fasciitis. Actually it's a skin, that is a dermatology emergency. You can say it is uncontrolled spread of bacteria, especially anaerobic bacteria pyogenes, into deeper tissues and this is out of proportion. You can see it is also forming crepitus. Crepitus means the methane and carbon dioxide are released by this pyogenes bacteria, and if you press that you will get sound. So actually this pyogenes bacteria is called flesh eating bacteria. You can see it is how like it is looking like flesh eating. Okay, flesh eaten already. So it also causes bullae, skin necrosis, and violaceous color. Like colors will be changing from red, purple, blue, gray, many colors you can see as here. Some are purple, some are pink, some are gray, black. Okay, and this is a surgical emergency, and it is also very painful if you palpate on this. And this necrotizing fasciitis is divided into two types. You can see here it is of two types. Type 1 is polymicrobial, occurs after surgery. Type 2 is a group A streptococcus, forms this, occurs in healthy people after skin injury. So because of some skin injury it may form secondly, that is type 2. Type 1 is after surgery. So here there will be fever, hypertension, pain out of proportion. Next, coming to staphylococcal scalded skin infection. So this one is scalded skin. You can see how it is scaling off. So this is because of exotoxin, which destroys the keratinocyte attachment in granulosum. Actually, in stratum granulosum, cells are attached by means of desmosomes. So if those attachments are gone, by keratinocytes, okay, if those keratinocytes attachment is gone because of exotoxin released by staphylococcus, that will lead to this problem. Whereas in toxic epidermal necrolysis, it destroys epidermal dermal junction, but here only stratum granulosum is lost. It is characterized by fever, necrolysis, generalized erythematous rash, sloughing of upper layers, and heal completely. It is positive for Nikolsky sign, which is separation of epidermis upon manual stroking. So if you do stroking normally, for example, if you try to scrape this off, it will come off. That is because of Nikolsky sign positive, that is epidermis coming upon manual stroking of skin. Commonly seen in newborn children, adults with renal insufficiency. Treatment is antibiotic because it is because of bacteria. Okay, very important. It is because of stratum granulosum keratinocytes detachment by the exotoxin of bacteria, especially staphylococcus bacteria. Now coming to the infections, first infection is herpes infection. Actually HSV1, HSV2 of the skin can cause this from any mucosal surfaces to normal skin. This include herpes labialis, genitalis, whitlow. This is whitlow seen in finger. Next, coming to molluscum contagiosum, is umbilicated papules caused by pox virus. It is frequently seen in children and also sexually transmitted in adults. Next, coming to varicella zoster, there is no diagram. Actually, it is caused by varicella, chickenpox, or zoster. They present with multiple crops of lesions in various stages, like you can find sometimes vesicle, sometimes crust. So zoster is reactivation of virus in dermatomal distribution unless it is disseminated. Next, coming to hairy leukoplakia. Actually hairy leukoplakia is irregular white patches. Somewhat can see the whitish patch here. It is painless plaque on lateral tongue. It cannot be scraped off. If you try to scrape it, you can't scrape it. It is Epstein-Barr virus mediated. Mainly occurs in patients who already have HIV and also some who are having organ transplant recipients. Contrast with thrush. Actually thrush is scrapable, and also leukoplakia is precancerous and it can be scrapable, but hairy leukoplakia can't be scrapable. It will be white like that only. Even if you try to scrape it, it will not come.